afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager based at the IMST in DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you, Director. So good morning, good afternoon, and good evening, depending on where you are. It's my honor once again to take the press briefing today on behalf of our Director General, Dr. Jean Kaseya, who is not able to take it. And I'm taking it from Addis Ababa, where colleagues from the member state, from the different partners of the IMST are meeting to discuss and pause and see how we are moving the Mpox beyond the facts that have been maintained and how we are going to transition it in the national health system. Over to you, Dr. Director. So we'll start by some very encouraging news. As you can see the pictures. They are the picture of the two patients that has been discharged from the Ebola treatment center in Bulape in DRC. So this is a very positive sign, though we'll come back to the actual outbreak in a few. Next slide. As mentioned, we are currently in Addis Ababa at the headquarters of Africa CDC with around 80 participants from our member state, all those that have been affected by the Mpox for the last 1 year, pausing on what we call an interaction review. And this is the time when we pause and we ask ourselves three critical questions. What went well? What went less well? And what are the actions that we want to implement in immediate, mid, and long term? We did the same exercise last year in December, still in here in Addis, and that has led to the response plan 2.0 that has ended in August. So following the maintain of the facts by Africa CDC, the maintain of the grade 3 by WHO Afro, it was critical, one, to agree on what are the critical actions that we want to implement in the next 3 months, but also on how the countries, the member states, will actually integrate Mpox within the health system. And this is a critical exercise that needs to be done with the member state, with all the different partners, to ensure that we are aligned with the support that they will require so that we control the Mpox and we can think also what will be the long-term action needed to move toward the elimination of Mpox. Next slide. So from this key discussion, we have been moving around and agreeing on the key drivers that are critically needed to control Mpox, especially in this era where the resources are limited and where we are all asked to do more with less. So the key drivers are the political engagement at the highest level. We've seen the example of many countries, and they were doing the testimony on how the support at the highest level in Sierra Leone, as just one example, has managed to really change the way they've been responding to Mpox. And others, it has helped them to invest on community-based surveillance and all the different aspects that are critical, the laboratory decentralization, the isolation of the case. So the key driver that I critically need as soon as the case are be seen. So this platform was really an opportunity to have countries, high-burden countries, including Sierra Leone, I already mentioned, Uganda, DRC, Burundi, sharing their experience with other countries where we see some upsurge, Liberia, Kenya, and so on, but also others who have very few cases, like Cameroon, like Cote d'Ivoire, and so on. So this platform has brought us to the way forward on building the community of practice, where the member state will have the information that I need as we move in the transition toward the elimination of Mpox. Next slide. Now, looking at the overview of the public health event in our continent, still we have those top 5 public health events, including Mpox, cholera, measles, dengue, and Lassa fever. We've mentioned last week the critical event that happened in Cote d'Ivoire on Lassa fever, where the leadership of the West African, supported by WOW and with the alignment of Africa CDC, on how we can push the research, how we can push the local manufacturing agenda in producing the countermeasure, the vaccine and others, so that we can address this critical event, which is Lassa fever. Next slide. Going now to DRC, where the Ebola virus disease is still happening. So now, as we do speak, we have a confirmed case that was from the 28th of August. Now we count 7 deaths as compared to 0 in a week to 37. The male, we have a male female ratio which almost 1:1. And what is important here is to see the case to contact ratio. We can see that for one case we have at least 20 people who are followed up. And that is critical. That is the key indicator, emphasizing that we control the spread of the outbreak. Now, it's critical to ensure that the community-based surveillance is in place in all the different health zones that I will mention in the next slide. In terms of vaccination, already 613 people have been vaccinated, and amongst them, the health workers. You remember that the first people who died were health workers, the nurse and the people from the lab. So it's critical to ensure that those ones also are protected. That's why you will see that 10% of the people vaccinated were the health workers. Next slide. Now you see the area of Bulape, which is a health zone. And within Bulape, you have those 6 health areas, which we call aire de santé. And you will see that Bulape, within it, it's also where we find quite a number of the confirmed case, but also the suspected case. Now, in terms of screening, it's critical, the screening within the health zone, but also at the port of entry to ensure that the control is really happening and we limit the spread of the disease in the neighboring health zone. So you see that 339 people have been screened on the Mweka, Bamba, and also Bakodashi, but also the finalization of the installation of ultra-cold chain, which is critical for the vaccination, because the vaccine that we have need to be conserved in a very cold chain. Now, the good news also is on the treatment. The Bulape Ebola Treatment Center has increased its capacity, moving from 21 beds to 34. And as now also, as we wanted to strengthen the community-based surveillance, the briefing of community healthcare workers, who are the one in the community, ensuring that one, all the suspected cases are identified, and those who are suspected now are transferred to the treatment center where they can be isolated, but more importantly, where they can receive appropriate care. And this is what happened to the 2 patients that have recovered from the disease and have been discharged. So this is very positive. They have been treated with the MAB 114 that has been discovered and assessed in DRC. So that this is a very positive and encouraging news for the response into Ebola. Next slide. Now, going back to Mpox, in the continent, we gladly see the continuous decrease, though we all agree during this week that we need to be very vigilant. We need to strengthen, to accelerate as much as we can the community-based surveillance so that we can reach to the 0 case scenario, which was the key activity in Sierra Leone. This week we have 1 death confirmed as compared to 4 last week. This is also encouraging because the case fatality ratio is one of the key indicators. First of all, we want to save life, and second, we want to stop the spread of the disease. So having the decrease in the number of deaths is also quite encouraging. And as you see, there is a significant decrease in the number of confirmed cases when we compare the peak season as where we are right now. Next slide. Now, when we look at the percentage of change in countries, we can see that Mozambique, though the number of cases is not the highest, the percentage of increase is the highest, around 247%. What it means? It means that Mozambique is definitely one of the key countries where the 5 drivers that I mentioned earlier are critical to ensure that we control, as we still have around 76 cases per week. We really need to ensure that we control in the hotspot. Now, the countries that are the most challenging, as you can see now in terms of increase, but also in terms of number of cases, those are Kenya, Guinea, Liberia, Ghana, and Nigeria. Next slide. Now, going to DRC, we continue to see the stabilization, a small increase between 122 to 173 cases last week. We can see that the number of suspected cases have decreased, which is also encouraging. But what we are quite comforting is the test positivity rate, which is around 41%, which means that the majority of the cases that we find are still found in the community. So that is quite encouraging. The testing coverage also have increased, though last week we had some challenges in some laboratory, bringing it down to 29, while we were already around the 69%. Next slide. Now, looking at Sierra Leone, we continue to see the decrease in the number of cases, though we've not managed to have the 0 case by the end of August. Still, we have had only 21 cases in the last week, and then those ones are localized in the western area. So you can see that in the last few weeks, we've seen a 90% reduction, which is quite significant. And a lot of effort has been done, not only on the surveillance side, but also on the laboratory side. As you can see, the sequencing has been done for almost 10% of the positive case, while the threshold that we are recommending is 8%. And more importantly, also the vaccination, the integrated approach for vaccination are being quite successful. What it means is that the surveillance, the community, the IPC, but also the expert on vaccination was working hand in hand. Now, in Uganda as well, we continue to see the decrease in the number of cases from 81 to 26 this week. Also, happily, there's been no death. And the test positivity rate also is quite low, 18%, which means that the screening is pretty good in the sense that they managed to capture quite a significant amount of suspected cases, and most of them are turning to be negative. So that is very, very, very encouraging. What is also encouraging is that out of the 120 districts that were affected, right now we have only 40 that are remaining. And those are the districts where all the effort have been will be implemented. Those what are around Kampala, but also Mbarara. Next slide. In Liberia now also, we have been concerned by the increase on the number of cases, though we see a slight decrease. But what remains concerning, and we will definitely need the critical support in terms of mission and engagement with the country, is you can see the test positivity rate is around 90%. It means that out of 10 people that will be tested positive, 9 of them will come by themselves to the health facility, which means that we don't have a proper control and understanding of what is actually happening in the community. This was similar two months ago, I believe in Sierra Leone, where they were having the same test positivity rate. And once they were supported with the community-based surveillance in the integrated approach, they managed to bring it down to 30%, 30 to 40%. So we believe that using a similar approach, supporting Liberia, we should be able in the coming weeks to reduce the burden. Especially, we see that the cases are actually, most of them around the MODERATOR that account for more than half of the confirmed case in the countries. Now, the other challenge that we might face in Liberia is that 88% of the cases are being managed through home isolation. So ideally, home-based, when it's well implemented with the right infection and prevention control solution, then we are confident on the protection. But when on one side we see that the patient are mainly managed at home, but on the other side we also see that test positivity is so high, it means that we need to change something. We need to be closer to the community and then ensure that we do the proper isolation. Next slide. In Guinea as well, we keep on seeing the increase in the number of cases. We moved from 78 last week to 110 this week. Still no death as compared to last week, which is also quite encouraging. You see the case fatality ratio is quite low, around 0.3%, which is also quite encouraging. But it's critical to ensure that we control. And when we see the test positivity rate, which is quite low, it's also encouraging that they managed to capture the suspected case and the positive case mainly on the community. So it's critical now to work with the country, especially now that they will be receiving 20,000 doses of vaccine, to see what the most efficient way of using those doses so that they can really target the vaccination and go and target the vulnerable population, but also the key population. Those are the most at risk of transmitting the Mpox. Next slide. In Ghana, we continue to see an increase, though we are moving from 21 to 45 cases during the week. We can see also the number of suspected cases have increased. What is reconforting is once again the test positivity rate, but the testing coverage. So all the suspected cases are actually tested, and that is quite reassuring and on the way of controlling the disease. So what also is interesting in Ghana is that out of the 3,000 contacts that has been followed, only 10 tested positive for Mpox, which is a ratio of around 0.3%. This highlights the fact that on one side, the contact tracing is well done, and in the other side, we might be missing some of the key contacts because unfortunately, due to the disease itself, the sexual transmission of Mpox, it makes it difficult to actually find some of the real contact. Next slide. In Kenya, we gladly see that the number of cases are stabilizing with a small decrease from 30 to 23 last week, this week. We also see that the indicator in terms of testing coverage, test positivity rate are quite good. In terms, we can see 100% of testing coverage and test positivity rate around 38%. The country have also just completed the vaccination campaign of more than 10,000 people that have been vaccinated. We'll come to that a bit later. But this is also quite encouraging to see that the number of cases are reducing, but also that the vaccination is targeting the right people. So Mombasa, Busia, and Nakuru are currently the high burden and high counties. And we've also seen in the previous week that Nairobi was also seeing some cases. So for the new dose of vaccine that will come in the country, we will be supporting the country on ensuring that those that will arrive will keep on focusing on the key population, the key vulnerable population, but also in the geographic site where they are most needed. Next slide. Now, coming down to the vaccination that I've just mentioned. Vaccination, as you know, has been one of the critical pillar of our response. During the intra-action review, we were reminding ourselves that at the beginning of the response, before the effects was declared, what was expected for the continent was around 20,000 doses of vaccine. 1 year later, we are gladly seeing that 4,700,000 doses has been delivered to 13 countries, and then 3 million of LC16 has been delivered currently to DRC. Currently, we have 18 countries that have granted regulatory approval for MVABN, and 2 countries have also managed to have consider the person under 12, because we've seen that in some countries the epidemiology show that children also are at risk and therefore need to be protected. 11 countries have successfully rolled out the Mpox vaccination. As mentioned, Kenya just did the last round, which will come back once again. With the MVABN, more than 1 million doses has been administered, more than 1 million persons has been vaccinated with at least 1 dose. So now with the advocacy that we've been doing with all the partners, and when I say we, it's really the IMST, we will be receiving an extra 200,000 doses of vaccine coming partly from Bavarian Nordic, the producer of MVABN, and also with the support of UNICEF. That will give us a bit of air for those countries that are coming up and that are in the needs of vaccine, to really ensure that they're moving to the last mile. So we have some planned shipment for a vaccine for Ghana, Liberia, Uganda, and I mentioned those are the countries that are really on need considering the epidemiology. Guinea has also been considered, and then we will be receiving 20,000 doses of vaccine. In the other hand, also, we have some of those countries that are already considering the use of vaccinal dose. We've mentioned that a while ago, but we are moving forward with countries like Uganda and Sierra Leone and maybe also Liberia, who have granted the NITAG approval. And then with the support of our partner, we'll provide the syringes that are critically needed for them to use that new innovation to reduce, to actually be more efficient on the dose that we have. Malawi has just received 33,000 doses of vaccine. Kenya, as mentioned, they've managed to vaccinate 10,000 people with all the doses that they were having. So now they are expecting to have this new allocation. Next slide. On the side of the Mpox, the Ebola vaccination have also started in Bulape, as mentioned. So initially there were 2,000 doses that were prepositioned in DRC. 1,000 doses was sent to Bulape, and using those 613 people have been vaccinated, and as mentioned earlier, 68 of them were health workers. So since the beginning, the country has made some requests. Another 2,000 doses have reached the country on the 13th of September, and the ICC just approved an additional 47,000 doses that will be waiting the country to revise their plan on the needs, which means that as we do speak now, vaccination is not an issue on the side of Ebola, and therefore the population, the frontline workers will be the one to be protected. But saying that, the Ebola vaccination, it's not a mass vaccination, but really a targeted, what we call the ring vaccination, where around the positive case will vaccinate the contact and the contact, so that we have that ring, what we call the ring of people who will be protected against the Ebola. Next slide. Now, moving from Mpox to cholera, as you are not now used to, the cholera is part of the IMST in terms of management, and you can still see the increase in the number of cases. You see that we are in September, but we are already reaching the total number of cases that we have last year. There were 254,000. Now we are 253. The number of members that also is higher than what we had last year. That's why it was critical to have that coordination so that we can respond at continental level to this cholera. Next slide. So in terms of country per se, we have the top 3 that are Chad, Congo Republic, Burundi, and you can see the percentage of change, which is quite high. In Chad, the total number of cases is 1,858. In Congo Republic, where the team will be supporting next week in terms of surveillance with the deployment of 200 community care workers in partnership with WHO and all the IMST member present in Congo. Burundi also, we see the increase in the number of cases. So those are the country where we have the riot, those are the new outbreak. But still, you will see that in terms of cumulative number, country like DSC, Sudan, South Sudan really remain the top country in terms of high burdens. But we can see the decline of around 64% in South Sudan. In Somalia, it has reduced from 59%, Angola 72%, and DSC 26%. That's why it's critical to have that coordinated approach to ensure that we bring the attention where it's critically needed. And as you see right now, Chad, Congo, Burundi are the key countries where we see a surge in the number of cases and the number of deaths as well. Next slide. So going now to Congo, we can see that good enough this week there have been no deaths as compared to the 27 that was reported last week, so that is also quite encouraging. The hotspots remain the Ilmbamu, Mosaka, Gamboma, and the Congo Ubangi. And then the driver, still the same. The outbreak is concentrated in high vulnerable riverine area and poor sanitation. This reminds once again the critical need of the multi-sectorial approach. That's why you have this IMST where the WASH will be playing a significant component, but also the ministry in charge of planification on water to make sure that the population that are living in those places actually have access to clean water. Next slide. In Chad, you see that the case fatality ratio is around 6.2% with 421 deaths out of the 58 suspected cases. We can also see that the number of cases are a bit stable from 410 to 418. The number of deaths are also increased slightly, but this is still too much death. 29 people died last week because of the disease that we can prevent and we can treat. So that's remain a critical urgency. In terms of hotspot, we have Wadai and Sila that are the critical hotspot. The attack rate is quite high with 76.8 per 100,000 population. Now in Chad, the driver is a bit different than what we've seen in Congo. Here is the movement of refugees from Sudan and overcrowded IDP camps and poor awareness and good practice. We have the mass gathering, we have the open defecation. All those drivers are the critical component that is fueling this outbreak. That's why the approach to respond will definitely not be on the medical side, but also on how we make available the water, but more importantly, how we educate those populations with the right tool in terms of access to toilets so that we can stop having those challenges of open defecation that are contributing significantly to the spread of cholera. Next slide. In South Sudan, we continue to see the decrease, the significant decrease with a case fertility rate that is now at 1.7%, which is quite reassuring. This is thanks to all the efforts that has been implemented in the countries. And the ongoing population movement, the flooding and persistent humanitarian crisis has been the driver that we've been seeing. But this is an example of when the resources are mobilized, including the vaccine, then we can see the decrease and the positive outcome on the responding to the outbreak. Next slide. So to summarize, the Ebola outbreak in Kasai consider still a major threat to the national system, but also the country around Angola, for example, is preparing because it's critical to be prepared with the monitoring, with increasing the screening at the point of entry. It's quite encouraging that we have 2 patients that are being recently discharged after recovering using the treatment, the MAB 114, which is also reminding us the importance of research on providing innovations such as this treatment, but also the vaccination that is now being available with 600 people who are being vaccinated in Bulape. In terms of spread, we have these 6 health areas within Bulape. Those are where all the attention is currently, while the surveillance is happening in all the health zones that are around Bulape. So now in terms of priority action, going back to the surveillance and ensure that all the contact and the contact are being followed, are also being vaccinated, that is critical. The cross-border surveillance to ensure that we don't extend beyond the health zone of Bulape. And of course, scaling up the community and engagement, because the behavior of the community are key on controlling the outbreak. Next slide. Now, moving to Mpox, we are gathering, as mentioned, currently in Addis Ababa for the intra-action review at a time when Mpox remained a public health emergency of continental security, a great event as confirmed by WHO, which means that the regional resources are mobilized to move to the last mile and ensure that the country has what it takes to include the surveillance, the control of Mpox within the national health system. So happily, we have those 200,000 doses of vaccine that are being made available and that will be affected to the country that we've mentioned that are in the need while the doses were no longer available. So it's also an opportunity to appreciate the global solidarity that we are seeing in the response to Mpox. Next slide. Now, moving to cholera, we see that we have countries like Chad, Burundi, Republic of Congo that are where we are seeing the sharp increase with high case fatality rate, where most of the effort will be implemented, as well as the continued monitoring in countries like DRC. So now, to achieve that, the critical point is definitely the resource mobilization, and the upcoming UN General Assembly that will start by the end of this week is an opportunity to mobilize resources so that we have what it takes to respond to this outbreak. As we've seen in South Sudan, when the resources are mobilized, we have the vaccine, we have the ORS, but more importantly, we have the access to clean water, and then we can control the outbreaks. Next slide. So with that, I will thank you. I will hand over to Director Margaret, and happy to take the question for our dear journalist.
Thank you very much, Prof. Let's take the first 2 questions. I have one from Kumba Lay, is a reporter with the Gambia Daily. The question is, with climate variability driving cholera outbreaks, is Africa CDC developing a framework to integrate climate resilience into epidemic preparedness? That's the first question. And then I have another one here from Christina Okello, a Radio France international journalist. The question is, the WHO has lifted the global emergency on Mpox, but cases persist in Africa. How can this gap be explained? And then last question is, after the global emergency has been lifted, what guarantees are there that Africa will have the necessary vaccines and resources against Mpox? Back to you, Prof.
Thank you so much for those 3 critical questions. The first one was on the climate resilience. Last week there was the climate summit here in Addis, and Africa CDC was quite present on the side of our Director General, but also all our team that are working critically on ensuring that our activity, our action are taking in consideration the climate change. You've seen that the flooding that has been affecting Sudan, South Sudan, even DRC, have been some of the key drivers on the spread of cholera. That's why at our level, the first thing is critical to assess what are the trends on those climate change, which will be released on the next week on the 22nd of October. The Conference of Public Health in Africa will be releasing our Public Health Intelligence Report. And within that, we've been following how the climate has been affecting the health in our continent. So having those evidence, those data, not only for cholera, but for other situations, therefore we adapt our response to ensure that the country are supported, capacitated on how they can prevent and respond to those public health events. So now the second question was the issue on the gap, on the lifting of the FEC by WHO and the maintaining of the FECs by Africa CDC. So first of all, it's important to remind that we have that ECG, the Emergency Consultative Group, which are all experts, African experts. So they look at the trend of the Mpox situation in the continent. They look at the dynamic of the disease, or the effort that has been implemented, or how it has led to the decrease of the case in the continent. And this was quite encouraging. But on the other side, they were also assessing the number of countries that were having those new cases. When we were having the FEC declaration, we were having around 13 countries affected. Now we are around 25 countries at the time we were having these new assessment. So having that, and also having that the case fatality rate was happening in people living with HIV, and considering the impact on availability of ARVs due to the reduction of the ODA, especially the PEPFAR, it was a concern that how are we going to support those ones if we don't have all the coordination, all the resources mobilized that we have for during the FEC. So it was critical to maintain for the epidemiologic reason, but also to ensure that we control. This is at the level of Africa CDC. Now, at the level of WHO AFRO, which is the component of WHO at the continental level, they decide to maintain the grade 3. What it means that all the continental resources are still mobilized to respond to this outbreak in the continent. So this is truly an African problem. And therefore, all the resources are mobilized at the continental level to ensure that we have the resources, we have the technical support for our member state. Now, the question that is being raised on the vaccine availability, whether it will reduce the vaccine availability, I just mentioned that we are receiving 212,000 doses of vaccine. 1,000 of them will come from Bavarian Nordic, and 112,000 will be coming from UNICEF, which means that the mobilization of vaccine will continue, the global solidarity will continue. So it's a strong message that we want to carry, saying that we don't want to repeat the same mistake that we had in 2023, when the FECs was lifted while the cases were continuing in the continent. Now, as Africa CDC, we had the capacity to declare the FECs and to assess, and then we appreciate the recommendation that we still need to maintain to make all the effort. And as I mentioned, we are currently in Addis to ensure that the country are equipped for the transition of Mpox response within the national system.
Thank you, Prof. Let's cross back to the floor. We have Janice from Bloomberg. Janice, you have the floor.
Hi, good afternoon, and thanks again. There was a Lancet Global Health paper out today about calling for a fairly unusual form of diabetes to be classified as type 5 diabetes. And what this form of diabetes mainly shows up is in people who were undernourished as children. I was really just wondering, you know, as we look across the continents in terms of repeat famines, in terms of climate change, if this is something that the Africa CDC has on its radar, if it's concerned about it, you know, there are ongoing problems with getting insulin to people across the continent. And yeah, just wondering what your thoughts were on that.
Sorry, Janice, we were not able to get the question.
All right. Can you hear me adequately now?
Yes, a bit better.
Okay. I'm really just, there was a paper out in the Lancet Global Health today looking at a classification that they were calling for an unusual type of diabetes, and they were wanting to get it classified as type 5 diabetes. And what this type 5 diabetes is typically shows up in lean young people who have been undernourished while they were in gestation and in early childhood predominantly. And I was just wondering what the Africa CDC's thoughts were on this and if it was on their radar, because we've obviously seen repeat famines across the continents. And we know that with climate change, that could get worse. But at the same time, we also know that there's a lot of difficulty in getting insulin to people across the continents. And yeah, I was just wondering what the Africa CDC's thoughts were on this classification and on the potential surge that we could see in the next 10, 15 years related to this kind of diabetes.
Okay.
Yeah, back to you, Prof.
Okay, thank you, thank you. Initially, it was a bit difficult to get it, but definitely within Africa CDC, we have a whole division tackling the issue of non-communicable disease, where the diabetes will fall. That is one. Two, we are going to release, as mentioned, our public health intelligence report, where we are also following the trend for those diseases. And we will have those experts who will be meeting on Durban, and I really encourage some of you to register for the SEFIA 2025 so that we can see where we stand currently. For this specific article, I've not been aware, you mentioned that it was published today, but I'm convinced that our colleagues who are leading the NCD division might be quite aware. And then once we will get a bit more information, we'll be happy to give you some feedback on the position of Africa CDC on that.
Thank you, Prof. Let's take the next question. We have Kate Lay from The Guardian. Kate, you have the floor.
Hi there, thank you for this briefing. I wanted to ask you about some reports this week that the US government has reverted to calling Mpox monkeypox, and whether that sort of change in the name that's being used is like to have any practical implications.
Thank you, Kat. Let's take the next one before Prof comes in. We have Paul from The Lancet. Paul, you have the floor.
Yes, thank you very much. So my first question has to do with the WHO's decision to end the public health emergency declaration for Mpox while Africa CDC is maintaining its own emergency declaration. We know both organizations are working together and responding to it. So the question is, what has changed in WHO's involvement or in the response? Then the second question I have has to do with SEFIA in 2025. I want to ask, what is the preparation you have to ensure adequate representation of African countries, considering it's not every African that can come to South Africa without visa? Registration has not even started on the website yet, and it's like a month to the conference. So what was the rationale for this very short announcement of the conference, and what is being done to ensure that this short process does not truncate or discourage African public health experts from attending? Thank you.
Thank you, Paul. Back to you, Prof.
Thank you. Thank you so much for those critical questions. The first one on the change of name from Mpox to monkeypox, what are the practical implications? First to remember that initially it was called Mpox, and then it was a group, especially African researchers and scientists, who raised the point that it's quite stigmatizing. That's why it's critical to go to something that is less stigmatizing, Mpox. Now, going back to monkeypox can be a challenge on that specific argument of stigmatization. But however, in terms of implication at our level, we'll keep on carrying with the denomination that we have, and it won't change much on the way we respond and the way we address the Mpox. I think that's the most important part to have in mind. Now, the question from Paul of the Lancet. So just to mention that I say that we are currently in Addis Ababa for the intra-action review. And in this intra-action review, we have the co-lead of the IMST. The co-lead of IMST is Africa CDC on one hand and WHO Afro in the other hand. And as we do speak, we've been engaging for the last 4 days with all those partners, and they were represented in different pillars, vaccination, laboratory, and all of them, just to highlight that in the way the IMST is responding, WHO is quite present, and they will continue. 2, at the global level, the commitment to support Mpox has been extended to August 2026 by the Director General of WHO, Dr. Tedros. So what happened now, it's at the continental level, WHO Afro also assess at the global level, they say the fix is lifted because there is no threat at the global level. And we can see that the number of cases in Europe, in US, and others have not raised since the last year. But however, the case still increasing in the continent. That's why at the level of WHO Afro, they decided to maintain the grade 3, which has been there before. So which means that the engagement of WHO remain the same on how together within the IMST we respond. So I think that's it's critical. And I think we should focus more on how we will support the member state on the transition. Because even in 3 months, we will be happy as Africa CDC also to have the recommendation to lift the flex. It will mean that we control in all the member states. We ensure that also they are all the member states are ready to handle them by themselves. This is really where we want to see our continent. Now, for the safe year, just to tell you, now we have more than 4,000 abstracts, which is showing the great interest. And then it has been a challenge, I think, to be quite transparent. It was supposed to happen in Morocco. Unfortunately, it was not possible. And we had the opportunity to have it this year in South Africa. Why is it a critical opportunity? This is the place where we have the G20. So it's critical to have all the scientists, all the health experts together to have all the outcomes. We'll have some head of state, we have all the Ministry of Health, will come all together, and all those outcomes from this conference will definitely be used just after also to influence on the G20, because there is no way we will continue to handle our health issue on using a singular approach. The multi-sectoral approach means that we bring the health at the 3 level, and this is what we've managed to do within Africa CDC, to bring the health issue at the political level, where we have the head of state who are assessing, we are dealing with a challenge at the strategical level, and then at the operational level. So this is definitely the safe year in South Africa. It's an opportunity that we cannot miss. Of course, there are some few challenges that we are addressing. There was a team that was last week in South Africa to see how we can facilitate the issue that you've just highlighted, including the visa and all the administrative support that our participants may need.
Thank you, Prof. Let's take the next question. We have Emery Makumeno from BBC. The question is, we understand that more vaccines are either in country or already ordered. Is it possible to know when the additional order reached the DRC? And how about the treatment molecule? What is the stockpile of treatment available in the country? That's the question from BBC. And then there's another question here from Judy. The question is, how can we create decentralized local cost emergency healthcare ecosystem in rural parts of Africa? I'm trying to build one and need some suggestions. Back to you, Prof.
Okay, so the first question from Emery from BBC was on Ebola, definitely. And the question was about the vaccine that are needed and those who have arrived. So initially, when the outbreak started, there were a stock of 2,090 doses per population in DRC. So when those start to be used, the first 70 was used for the frontline workers that were going to the field, so that to ensure that they are protected, and then 1,000 went down to Bulape. And as soon as they start using those doses, they made a first request to ICG, and 2,000 doses arrived in the country on the 13th of September. So currently we have the initial 2,000, then this batch of 2,000 that arrived. And I mentioned the country made another request, which has been approved, of 47,000 doses that will be available. Now, what the country is working on is to revise their plan based on the evolution of the epidemiology, based on the prediction, based on the strategy of vaccination. Remember that what we do, we vaccinate the contact and the contact, which means that when you have one case, you might think of 200 people that we might want to vaccinate to ensure that we have a good geographical location. And that has to be done within a certain amount of time, within 10 days, 7 to 10 days, to ensure the efficiency. So in terms of vaccine, they are available, and as you've seen, within 2 to 3 days, once the approval is made, the vaccine can be in country, and it might take 1 or 2 extra days to go to the field where they are needed. So in terms of treatment, the patient has been managed using the MAB 114. 100 treatment protocol were available, and there are some other discussions that are going on with the antiretroviral that can be made available. So I don't have the exact figure of what is available currently, but once we have them, we'll ensure that we make them available for you.
All right, let's take the next question. Move back to the floor. We have Kumba from the Gambia Daily. Kumba, you have the floor.
Thank you very much, Madam Margaret. Thank you for that presentation, Dr. Yap. My questions is, given the ongoing Mpox outbreaks across multiple countries, what specific strategies is Africa CDC implementing to prevent cross-border transmission, especially in regions without porous borders? Regions with porous borders, rather. The other question is, what is the current status of vaccine access and availability for Mpox in Africa? And are there any plans for continent-wide procurement similar to the COVID-19 model? And also, how is Africa CDC working with national health authorities to counter misinformation and stigma around Mpox, which often undermines community outreach or community response? Thank you.
Thank you. Back to you, Prof.
Thank you so much, Kumba, for the very interesting and very specific question. So the first one is what is being done to prevent the cross borders. And you're right, this has been one of the key discussions that we had during the week. And there are different opportunities, different strategies. We were having the colleagues from Uganda, from Kenya, who share borders, who were agreeing that currently what they do to control is they share data, they share some information, and more importantly, they train the community health worker within the same region so that they can emphasize the community-based surveillance in the region where there are some borders. Now, ideally, and what we strengthen is the surveillance at the point of entries. But you see now, Mpox, when not all the patients will have the rash that are clear, that are easily seen. When you move to genital symptom, it's hard, even at the point of entry, even when you have the tool, to be in the right position to make the detection of those ones. So critically, what we support is, one, the sharing of data. So we are moving toward a process that will start in terms of having a memorandum of understanding so that countries can share more easily the data, that's one. But also that when we have one case, we should be able to follow the contact from one side to another side without having too complex strategy. Now, the other thing that we do is to ensure that sorry, there is the cross-border mapping, so that we know exactly what are the hotspots where the patient can be found and what are the mobility from one side to the other. And the last one is also how we can have some joint vaccination strategy around the border so that we can support the country on that side. The second question was on vaccine access and availability. A few months ago, we were telling that we were having 0 dose of vaccine available. So I've just mentioned that we are receiving 212,000 doses that will be coming. We have the different countries that I mentioned already, Ghana, Liberia, Uganda, that will be receiving the vaccine on between the 22nd and the 26th. Malawi, I just received 33,000 doses of vaccine. So on one side, we have some few doses available, and we are also trying to optimize those ones with what we call the fractional dose, where one dose we can have the ability to vaccinate 4 to 5 people. That is how we try to respond to, one, the emergency and the fact that the doses are limited. But what we've heard from our colleagues here is, as we move toward the transition, we need to think about the countries that are endemic. How can we actually prevent the population? How can we increase the immunization of those communities? And that will lead to the question that you were also asking of the sustainability and the availability of the vaccine. And then now we move to our local manufacturing agenda, knowing the dose of vaccine that will be needed for the continent, especially in endemic countries. That will provide a significant information on the demand of vaccine that are needed. We need 3 to 4 million of vaccine doses need to move the tech transfer and to have the local manufacturer. And once we have that, the vaccine will be available in our environment. So this is a work that is in progress, and this is what has been discussed during the interaction review, so that we have on one side strategy, but also the other side, the demand. So in terms of information, as we mentioned, we've done a very large study in 9 to 10 countries, where we were understanding what are the trusted channels of communication within the most affected countries. We've highlighted television, we highlighted radio, and also health workers. So once we know the channels, this week we are also discussing how do we ensure that we capture the infodemia using the repeated survey on one side, using also all the tools, including the use of AI on tracking the infodemia on the different channels, the WhatsApp, the Facebook, and others. So having all those tools that allow us to assess the quality of the information and therefore to adapt the message. This is what we are currently doing to ensure that the population has the right information. And of course, this press briefing is also an opportunity, because when we send the message, you having the right information, we now send them to your community in the different countries where you are living.
Thank you, Prof. And with that, we have come to the end of the briefing this week. I'll hand the floor back to you for your closing remarks.
Thank you, Margaret. Thank you, dear journalist, for the opportunity that you give us every Thursday to be accountable, not only to you, to our leaders, to our communities. And at the time where we pause in Addis to do our interaction review, it's an opportunity for us on behalf of our Director General, Dr. Jean Kaseya, to appreciate the work that all the colleagues from Africa CDC, WHO, all the partners, but more importantly, all the member states. There were 80 of them this week to show all the effort that they have been implementing on responding to Mpox, but also to the other outbreaks. So at this point, we will keep on giving you feedback. We appreciate the diversity of the question. We have some questions on diabetes, beyond the Mpox and so on. So we appreciate that you come to Africa CDC to get the right information. And therefore, we'll make sure that every Thursday and beyond that, we provide that information to make our continent safer. Thank you.